Hello, everybody. My name is Trent Nessler, and I'm honored to present to you today on the use of technology for objectively assessing risk and return to sport. Obviously, for all of us, this is a huge hot topic on how do we or can we truly objectively measure risk, specifically biomechanical risk factors that we know put athletes at risk for ACL injuries and lower extremity injuries, and can we use those kinds of things for making safer and more informed decisions for return to sport? So first, a little bit about my background. My name is Trent Nessler. I am a physical therapist. I've been a physical therapist for over 25 years, and I've spent really the last 20 years researching ways to prevent ACL injuries in youth athletics. So I started on this journey over 20 years ago after 22 kids came into my office after ACL reconstruction over a 2-week period of time. And as I was rehabbing these kids, I was seeing certain movement patterns that I knew intuitively put them at risk for injury. And that really, quite honestly, started my journey. I started my journey by going back to school, did a doctorate with a focus in biomechanics and motor learning to really try to find ways to objectively measure athletes for return to sport. So we started with some wearable sensor tech, or I'm sorry, with video technology. We went to a motion captureless system, and then to where we are today with some wearable sensors. I'll talk to you about that journey a little bit more as we go through the process today, and share with you, really more importantly, some of the things that we've learned and how it has truly affected the way that I treat somebody, but also how I treat or how I teach others of what these movements are truly teaching us. So obviously I'm a physical therapist by trade. I've also got some other things that I do from a combative standpoint. I am also a combatives instructor. Love pulling in the biomechanics piece into that, the injury prevention piece of that. I also published a book last year called How to Build a Badass Firefighter. So if you're looking for something, a resource to really dive deep into all of the science and the science behind all the things I'm going to talk about today, it's a great resource. It's 350 pages, 1,400 references, and it really is a deep dive into the movement. Now, although it's related to firefighters and first responders, there's a huge application to tactical athletes in general, as well as our athletes as well. So what really started me on this journey, as I shared with you, really it was kids coming into my office, but it was also the fact that unfortunately and sadly, the research really has not changed that much since I started practice back in 1997. There's over 807,000 lower extremity injuries in the US and in high school athletics every single year. And studies show that over 200,000 ACL injuries occur every year in the US. Now, some studies say 200,000, some say as high as 300,000. And that's a lot of ACL injuries, especially when we consider that over 80% of those are non-contact in orientation. Non-contact in orientation is good because those are the ones that we can potentially prevent. But sadly, despite all of this research, we're still not preventing them. So the direct cost that's associated with those $200,000 or 200,000 ACL injuries is over $5 billion in healthcare costs, and that is only the ACL. That doesn't include any downstream osteoarthritis. It doesn't include any revisions or any meniscal tears that occur later on down the road. That is solely related to the primary ACL reconstruction. So knowing that, we also know that 79% have osteoarthritis in 12 years, and there's over a 28% revision rate in 2 years. Now, the interesting thing is just, again, despite everything that we have learned, that revision rate really has not changed a whole lot in the last 15 years. That osteoarthritis rate really has not changed a whole lot in the last 15 years. And the sad part is that 200,000 keeps going up because as kids get more involved in sports earlier on, and as kids become mainstream to only do one sport, we're seeing all of those rates go up. But here's a really sad statistic, and that comes from this 2016 study by Wiggins, which showed that 1 in 4 youths who suffer an ACL injury will suffer another ACL injury at some point in their career. So not only as a physical therapist, but as a father, this really kind of upsets me because it makes me really think, why are these non-contact ACL injuries, why are they so common? And why have we yet to really figure out how to prevent these things? And can we truly prevent them? And what I will tell you is that, let me stop for a second to talk about this term prevention, because you're trying to prevent something that never really occurred. So did you really prevent it? So what you will hear me say often is I'm going to mitigate risk. So what we do know is that if you address the biomechanical risk factors that are associated with non-contact ACL injuries, you can in fact mitigate risk. Can you prevent? We don't know because it never really occurred, but we do know that you can mitigate risk. And we'll talk a little bit more about that. So it's really all of this that really started my mind thinking creatively about, like, how do we create a better solution? When I started to think about this, I really started to think about what are the true risk factors. And the sad part is that these risk factors have been out there. So the first studies that I started to read really started to be being published in early 2000s. So if you look at Timothy Hewitt, Chris Powers' work, which some of their original work back in the early 2000s really has not changed that much as far as the biomechanical risk factors. We are getting better at knowing things about that and ways and things that affect that. But really, the way that we assess that has not changed a whole lot. So some of the things that ran through my mind as I'm going through this in my head as a physical therapist is what are the risk factors? How do I address these? And what factors should we really be looking for? Now, you'll hear me talk about the term LSI, Limb Symmetry Index. Limb Symmetry Index is simply a comparison of your right side to your left side. But one of the things that we use for return to play is that limb symmetry index is 90% of your non-involved limb. Well, the problem with that is there's some major assumptions that go on with LSI being equal to your contralateral limb. One of those assumptions is that your contralateral limb is not being deconditioned. And I think we would all know that an athlete who's having ACL reconstruction, who is going through rehab, even though they're working out and even though they're doing things, they're not working out at the same level or intensity that they used to work out. So that limb is, in fact, becoming deconditioned. So when you're comparing LSI, you're comparing that to a deconditioned limb. Is that a truly good measure? I don't know. The other thing is that LSI automatically assumes that you're comparing that to a good limb. But we've all seen those athletes that when they jump off a box, both knees go in and they knock knees. Now, in that case, that athlete is 100% symmetrical. And I would think that any of us listening to this or talking about this would realize that that's symmetrically bad. And even though it's symmetrical, it's still, that athlete is still at risk. So how do we quantify that? Is there a better way to quantify LSI? Is there a better way to look at that? Should movement risk factors be categorized for the same sport by gender, by age, etc.? One of the things that I'm finding is that there is a big difference. There is a big difference between a female soccer player who is a forward versus another position. There's a big difference between a female soccer player who plays Division I soccer and who plays Division III soccer. They move different. We also know that there's a difference between a 16-year-old male running back, a lineman, and a soccer player. They all move differently, and what puts one at risk versus another at risk. How do we quantify that? And are there things that we should be considering as far as not only that, but demographic factors, your previous orthopedic history, your concussion history, and all of those things that also affect that? What if these same movement patterns also correlate to military personnel? The interesting thing is that when you dive into that, and you'll see that if you go into the book, you dive into that and you dive into some of the military research, is that the same biomechanical risk factors for an ACL reconstruction are the same ones that put a military personnel at risk for patellofemoral issues, which is the number one risk factor or the number one injury that they suffer in their initial military training. So Are there ACL risk factors that we're not measuring? Does that impact other links in the kinetic chain? If you have this, you'll hear me talk about dynamic valgus. Does dynamic valgus just affect the knee, or is there an effect on the hip? Is there an effect on the ankle? And then finally, is there a way to leverage what we're doing, what we see with our eyeballs? Like when we see somebody and we see that they're moving all jacked up, like, is there a way to leverage technology that we can capture that on a mass form, in mass data form? Because that to me would tell us a lot. If I had data on a lot of people, a lot of different athletes, I'm going to start to see movement trends way ahead of anything being published in the research. And that's really where I think that we all need to go as respective professions, is to be able to leverage these technologies that are accurate and they're reliable, and they've been validated, to capture mass data on athletes, because I think that's going to tell us a lot of information. So this is one of the things I put this in here because this is what my curiosity led to. In 2017, I'll share this with you a little bit more. In 2017, we released a wearable sensor technology to assess these biomechanical risk factors. We'll talk about those in a minute. And since that time, since 2017, we've collected data on over 70,000 athletes across the US. That equates to 110 million data points for human movement. So we're able to see that. We're able to see trends at a much higher rate. So some of the things, this is a particular snapshot of one of the movements that we look at, for example, a single leg squat. So what this allows us to do is actually see where your numbers should be. And this is based off of normative data. And I apologize, this is actually a single leg hop plant, which is a multi-directional hop. They jump forwards, backwards, out and in, lateral and medial. And what this shows us is that, the blue numbers are all of our normative data that's based on over 10,000 athletes. And then it shows us immediately quick visual cue after the assessment where a particular athlete is landing. And that to me is very impactful, because it lets me know immediately where I need to target in on that particular athlete. So this was developed over 20 years. I've had multitude of failures. I've had a lot of criticism by my own profession, just people, what I will say in life, you will have people that will be naysayers and people who will support you, and use those naysayers to drive you to do things better. I've had a lot of life lessons with this, and the beauty of this is that what I have learned today, I'm going to share with you today. What I have learned today has been a huge impact on the way that we look at ACL reconstructions. So this system is now being used by some of the biggest names in, I can't say them out loud, but some of the biggest names in sports medicine for making return to play decisions. And what I will tell you is that we get more and more data. As a matter of fact, I can tell you, we did launch a large study with Timothy Hewitt with Marshall University, looking at over 4,000 athletes. And what we're trying to do is whittle down to see, of the movements that we look at, which is the most predictive for primary ACL, and then more importantly, secondary ACL. So after they've made a return to play decision, are there certain movements that we should be looking more closely at for making those return to play decisions? I'll share some of what we've learned from that with you all today. So this is what limb symmetry looks like for us when we look at our system. And this is not only limb symmetry, but it also includes what we call LQI, which is limb quality index. So one of the things that you're going to see right here is you can automatically, at a very quick visual cue, is see where people are with a symmetry, but you can also see that if there are movements that they're symmetrical at, they also have some ability to improve on the quality of that movement. And we'll talk a little bit more about that. With this new system that we just launched a new system in July of last year. With this new system, we're actually capturing over 3,500 data points for every single assessment. And we're collecting this at a rate of about 2,000 to 3,000 assessments per month. We have about 450 systems across the US. We just launched to the UK, Australia, Canada, Africa, and the US. And my goal is by 2028 is that we will have data on over 1 million individuals. So when you think about that, think about the level, 3,500 data points on over 1 million people. That's a lot of data on a lot of people, which is going to do nothing but highlight trends to us so that we can learn from that. So why do I do that? Why do I say that about the data and about the importance of that data? And that really comes from Timothy Hewitt published this editorial in the International Journal of Sports Physical Therapy in 2021, talking specifically about the importance of technology and the way that technology is capturing this mass data. Fortunately, I had thought about this, back in 2016 when we were putting our system together, so we were able to bring all of that data together. But what, according to Tim's paper and from conversations that I've had, is that this is going to lead, the way that we are leveraging technology, the mass data that we're capturing from technology is going to lead the research, because I will be able to identify trends at a much faster pace than what you would ever do in research. Like I said on my previous slide, we're collecting data at 2,000 to 3,000 a month. What that means is that a lab would literally take an entire year to collect that many subjects, if not 2 years, right? On 2,000 to 3,000 subjects. And we're doing that every single month. And what we're seeing is that the rate of collection is constantly going up as we add more users. The beauty of that is, again, with mass data, is this is really going to allow us to mine the data to find out what important trends. I'm going to share what some of those trends are with you today, share with you what we're learning from that data, and then more importantly, help us create better predictive values or predictive modeling for what movements might lead towards what types of injuries and what types of risk, if that makes sense. So first and foremost, what are some of the biomechanical risk factors that we look for? Number one is dynamic valgus. And this is 2 studies. The first one was done in NFL players. On the NFL players, they had 156 ACL injuries. They found that 72.5 of them were non-contact in orientation. And the orientation of the limb during the non-contact, captured via video, because they're filming both practices and they're filming both games. And what they found is that the limb position during these non-contact injuries was this dynamic valgus position. So you see this young athlete here demonstrating what that dynamic valgus position looks like. The knee falls into an adductive, internally rotated position. And what we see is that when your knee falls in that position, not only does that put a lot of stress on your MCL, not only on your meniscus, medial meniscus, but also on your ACL. Now, one of the things I will tell you that we've learned is that there's 2 components to that. There's one, the magnitude. As you can see there, she's moving a fairly large amount of magnitude, but she didn't get hurt in that test. So there's a magnitude component. The other component is a speed component. So if that young lady had dropped into that dynamic valgus position at 420 degrees per second, she might have torn something. So what we find is that there's 2 major components to the dynamic valgus, and that is the magnitude at which you fall into that dynamic valgus and the speed at which you fall into that dynamic valgus. So, one of the things that comes out of this is, well, that's great. That's professional football players, but does this apply to my recreational athlete? Does this apply to my young soccer player? Does this apply, to the kids out playing flag football that tear their ACL? And what this other study did here in 2018 is what they looked at is 15 to 30-year-olds who had suffered a non-contact ACL injury. And what they did is they did a CT scan. And through that CT scan, they were able to see where the bones were bruised on both the femur and the tibia. And from the bone modeling, based off of where the bone bruises were, they could actually determine the position of the limb at the time of the non-contact injury. And guess what? That was also a dynamic valgus position. So this dynamic valgus position is the same position whether you're a recreational athlete, you're a firefighter or police officer who just happens to jump down and change direction and tear their ACL, or if you're a professional football player. This dynamic valgus is very important to measure and then start to control. So the first part of that is obviously measure. Other things that we look at, obviously, is a squat. Squatting, is such a functional movement. It's such a functional activity. And the interesting thing is that if you take a pediatric a young child who is just learning to squat, who's just learning to walk, and you watch them squat, they have the ideal squat. Their hip position, their knee position, their trunk position. They can sit in a low squat without loss of balance or anything like that. And something happens between that young age and as we mature in life. And one of the things that we see that happens is that people's squat gets messed up. And because squatting is such a huge part of most strength and conditioning programs, it's also a reason that we want to look at it. So we want to look at it because it's a functional activity, but we also want to look at it because it is also something is done very frequently as a part of our strength and conditioning. And so how someone squats is very, very important. So a couple of things that we know, number one, is that if you improve your performance on the squat, and that's why strength coaches do it, is if you improve your performance on the squat, you're going to see an improvement in your sprint speed and your vertical jump. So we know that there is a power component directly tied to squat, and that's why strength coaches love to do it so much. But the other thing that we see is that there are some things that we need to look at when you do a squat. So one of the things that we look for is that if I drew a plumb line right down the center of you and I had you perform a squat, your hips should remain relatively equal distance from that plumb line. If not, you're shifting your weight off one way and you're shifting your weight off the other way. Now, we call that a lateral shift. We've been measuring that now since really about 2016. But what the research calls that is a lateral displacement of the pelvis during a squatting motion. And what they've seen is that when people have this lateral displacement of the pelvis during a squatting motion, is that they're loading joints differently on one side versus the other. Makes a lot of sense, right? Your muscle activity is a lot greater on one side versus the other. Length tension relationships are different on one side versus the other. And that component can add to a significant change in LSI. Your right quad, if you're shifting towards your right side when you do squats, your right quad will never be, it will always be stronger than your left quad if you're shifting towards your right, because what you have to remember is not only you doing that under a squat rack, but you're also doing it when you get on the commode. You're also doing it when you sit in a chair. After rep, after rep, after rep, after rep, all day long, every single day, you're shifting your weight over to that side. So lateral shift is one of the things that we look for and that we feel that we should probably address. We'll talk a little bit more about that in a few minutes. Now, when it comes to core, I think core is sometimes way over emphasized. I wouldn't say overemphasized. I would say it's over talked about without true science behind it. And I have always felt that the core is absolutely essential. But what it leads to is all of these really funky exercises that people do and things like that. When in reality, what we can do is get back to some of the basics. And what we know from the research now, both with Zhang and the next study, which I'm going to show you, which is de Blazier, they showed that if you improve your performance on simple planks and side planks, not only do you reduce your risk for knee injuries, but also low back injuries, you also see an improvement in your power output. Now, that makes a lot of sense to me, because if your pelvis is nice and solid and it's stiff and it's stabilized, then what ends up happening then is that your quadriceps and your hamstrings can contract from a much more stable base. At the same time, your core also has to be super strong in rotation or stability in rotation. And I will tell you, is one of the things I put on one of my first slides is my experience in martial arts. And I've been training martial arts for about 10 and a half years. And what I will tell you, it's given me a whole new appreciation for how I manipulate someone's center of mass. Is that if I can take your center of mass posterior to your hip, all I got to do is tap your foot and you're going down. If I pull your center of mass over your right hip, all I got to do is tap your right foot and you're going down. It's the way that we do takedowns. It's a part of what we do in martial arts. Now, that being said, what we also know is that when someone jumps up in the air and they land, and then their center of their pelvis is unstable and their center of mass leans over this way, what do? They land and then they hop, 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 hop. They're chasing their center of mass. until they become stable. Now, that's so well known. It's called time to stability. So when you land the first time the clock starts, and the multiple hops that you get until you become stable is when the clock starts. Time from start to stop is called time to stability. The longer your time to stability, the more likely you are to suffer an injury. So we know that. What we see that when we have assessed thousands and thousands of people is that if your pelvis is not stable, which means your center of mass leans over, and then you start chasing your center of mass. Now, we don't want athletes doing that, right? I also feel that if you look up some of Mickey Hughes' work out of Australia, he talks about a contact, non-contact ACL injury. And I don't have this in my presentation today, but I think it's noteworthy talking about. Mickey Hughes, contact, non-contact ACL injury. So basically what that means is two soccer players go up, they go to head a ball, they connect shoulders. So my motor plan when I jump up to head that ball is that I'm going to land and my center of mass is going to be placed over my limb, and then I'm going to cut right or I'm going to cut left. However, when I jump up in the air and I head that ball and I knock shoulders with the other individual, now my center of mass is pointing off this way. When I land, my center of mass was meant to be over here. Now it's over here. When I go to cut, then what ends up happening is that my limb is in a much more disadvantaged position. Also, the force vector, if my center of mass is over here and I land, the force vector from my center of mass going through my knee is very different than if I landed with my center of mass over my limb. So control of your pelvis is absolutely essential. And I'm going to talk a little bit more about that in a few minutes. But more importantly is what has doing side planks on thousands and thousands of people done for me. And I'm going to share with you some of the things that I've learned from side planks because no one ever told me this. And if there's one thing you can walk away with today that I would love is that you start looking at side planks differently. Because here's an individual doing a side plank. I'm going to start at the foot and the ankle. The first thing that you see with this individual is what we call tibial drop. In a normal side plank, you should be able to stabilize your ankles so that you're holding your tibia off of the floor. Now, in this individual, and what we've seen is that when you have that tibial drop position, your peroneals and your anterior tib are not as strong as they should be. And what that means is that individual is 3 times more likely to suffer an ankle sprain simply because they cannot stabilize their ankle in a neutral position in a side plank. So no one ever told me I could use a side plank to look at someone's ankle and get something meaningful, clinically meaningful from that. That's the other thing. Let me stop for a second. What I'm going to be sharing with you is not just data. It's not just something that's just, pie in the sky. It's clinically meaningful information. What I want to be able to do is provide you with information that you can walk away with today and make a clinical change based off of that to change the way that that person moves. So here in the side plank, automatically, I'm going to be doing something for this guy's ankle. I'm going to be doing some strength and conditioning for that ankle. Next thing, if I go up to his hips and his hips drop down, the highest EMG activity is on that down hip in the glute medius. If his hip is dropping down, what that's going to tell me is that his glute medius does not have the strength and endurance that he needs to have. And therefore, it gives me something I need to target in on. Okay. Now, on the other hand, if his pelvis rotates backwards, that tells me a lot about transverse abdominis strength. If his pelvis rotates forward, that tells me a lot about quadratus lumborum strength. So sometimes what you'll see is that those athletes who suffer low back pain, a lot of times they'll reach back in their low back and they'll put their thumbs right on their quadratus lumborum and they'll rub and they'll say, man, it's always stiff right here. Okay. A lot of times when you test those people in a side plank, when they get into a side plank position, their pelvis is going to start to roll forward. Again, gives us something immediately that we can start to target. Finally, I'm going to go up to the shoulder. So that shoulder on the downward arm. Shoulder on the downward arm is obviously very active. But if his shoulders roll forward, what that begins to tell me is something about his serratus anterior and his rhomboids. If his serratus anterior and rhomboids are not strong enough, you'll often see their shoulders roll way forward. What we know is that that person, especially if they're an overhead athlete, they are 3 times more likely to suffer some type of a shoulder injury. And that can be labral tears, rotator cuff tears, also UCL tears. That being said, again, it's going to give me something I can target in on from a strength and conditioning perspective. More importantly, side plank is I can see now limb symmetry between all of these things. So if he flips over to the other side, does another side plank, but he doesn't have that tibial drop, or his hips don't drop, or his shoulders don't roll forward, again, it gives me a clue on limb symmetry related to those aspects of the side plank. So again, I share that with you because this is one of the things that we've learned from side plank that's told us a lot of clinically meaningful information, but something that no one ever told me. Again, this is where mass data comes into play because we start to see these trends prior to any research being published. And the beauty of that is that I can take that today and I can do something clinically with it to prevent that person from having an injury. So here's what our movement assessment consists of. We do a plank test, we do a squat test. So we do a 1 minute plank. We then do a 20 full squats. We do a right side plank for 1 minute. We do a left side plank for 1 minute. Then what we do is we do everything on the right side, and then we do everything on the left side. So we do right single leg squat test. We do a right single leg hop, just hopping straight up in the air. We do a hop plant, jumping forwards, backwards, lateral, and medial. And then we do an ankle lunge test to clear the ankle, hip, and knee. Then what we do is we flip over to the left side, and then we repeat all of that on the left side. Now, total, this is 83 reps, 3 1-minute time test. It isn't meant to be intense. It is meant to have some level of fatigue introduced so that we can start to see how do you move as an athlete. I don't want to see what you look like when you first get on the field. I want to see what you look like after you've been on the field. Now, there are some situations, not very often, but there are some situations like Division I soccer players, like some of our UFC fighters, where we will actually put them through a fatigue protocol first, and then we will put them through this assessment. Because there's some athletes that are just at such a high level, you have to introduce some other level of fatigue. And the fatigue protocol we use, in case you want to know, is called the FAST-FP. It's a functional agility short-term fatigue protocol. It was first published in the Journal of Athletic Training in 2012. It's the only fatigue protocol that's been shown to affect the biomechanical risk factors for non-contact injuries. So that's part of the reason I use it. It's super simple to do, only takes about 4 minutes. That said, I only do that after I've tested an athlete and I'm not seeing what I thought I would see. So, I say that from a risk perspective because you're going to see a lot of dysfunction on this test. And sometimes you'll see that even in your high-level athletes. So I would encourage you that if you're going to do the FAST-FP, first assess them to make sure that you're not going to overly fatigue them prior to going into this test. So this is a study done in 2021 talking about the poor validity of functional performance test. So here's the thing. All of these tests, the SEBTs, star excursion balance test, the single leg hop test, the single leg hop test for distance, drop vertical jump test, and the tuck jump test. All of these, as objective as we try to make them, some people use video technology with them yet. They'll use Coach's Eye, or they'll use Dartfish or something along those lines. Those tests are still subjective for the most part. That being said, studies show that they are not very predictive for new or for re-injury. So there is a poor validity to those tests. And those are the primary tests that we use for return to play. So we still use those for return to play. We still use that battery of tests for return to play. And yet the studies keep showing us that they are not predictive as far as for new injuries or re-injury. Now, that being said, why is that? Well, part of it is that there are factors that we have to measure that, quite honestly, I don't think we're good at measuring with our eyeball. What's the difference between 10 degrees of dynamic valgus and 20 degrees of dynamic valgus? Can you capture that with your eye? Can you capture the difference between 200 degrees per second of dynamic valgus and 400 degrees per second of dynamic valgus? Can you capture that with your eye? Can you capture the difference between 10 degrees of pelvic tilt versus 30 degrees of pelvic tilt? Maybe, maybe not. I don't know. the thing is that if you go across the board, across our multiple professions, our respective professions, that's not the case. You may have one or two people that can do it, but as a profession, we can't. And therefore, when the majority of the profession is making the calls based off of those tests, they're not very valid. So we have to find a better way of doing that. Now, these next two studies really kind of laid this home for me in why we need to do something better. Because this was a study by King. They looked at the movement patterns known to put people at risk for ACL injuries at 9 months post-op ACL reconstruction. So these were athletes who had gone through physical therapy. They had gone through physical therapy with a sports certified specialist, and then they were being returned to sport at 9 months. And what they found is that despite all of that, despite all of the rehab, despite all of the things that they've done, when they did an analysis, a biomechanical analysis using a Vicon system, they found that there was still a greater asymmetry in all measures at 9 months post-operatively. So when they jumped down, their knees went in towards midline. They had a dynamic valgus position. Their pelvis was not very stable, both in bilateral as well as single limb testing. Now, that being said, what that tells me is that we've got to get better at rehab. Like, you cannot be measuring movement at the end of rehab and be expecting to change movement on the front end of rehab. So how do we measure movement throughout the phases of rehab to make sure that we are building the foundation by which we progress to the next step? Because if you don't have a foundation of not having a lateral shift on a squat, then you're not going to have the foundation for doing a single leg hop. If you do not have the foundation for a single leg hop, you're not going to have the foundation for doing a multi-directional hop. So somehow we need to measure these things throughout the progression of rehab in order to make sure that our athletes are properly prepared. Now, this study took it a step further. Itherburn looked at these same similar set of athletes at 2 years post-op ACL reconstruction. And what they found is that although the bilateral dysfunction, so when I say bilateral dysfunction, simply measuring dynamic valgus, they did not measure lateral shift, because I will share with you what I see with lateral shift. So what they found, though, is that dynamic valgus improved with box jumps or drop vertical jump tests. They found that improved at 2 years post-op, but single limb did not. And if you look at B down here where this athlete is landing, this right here is the pelvic motion that I'm talking about, because athletes do one of two things. They either get this lumbar side bending to bring their center of mass over to correct for this, or their center of mass will go this way with it. So again, two different strategies, different results. So all of that said, somehow we need to get better at rehabbing this piece so that at 2 years post-op, they're still not dealing with this. This is why I firmly feel this is why we have such a huge injury rate, a re-injury rate at 2 and 3 years, because they're still demonstrating these movement patterns that we know put them at risk, but yet we've not done enough to change those movements. So the first step in my mind is really measuring that. So as I alluded to when I first started talking today, we started with, and I'm kind of aging myself here, but we started with beta cameras with the beta tapes. I was filming people in my office. I would film them doing a series of movements. From that, I found that it was not objective enough in my eyes. So at that time, I went to the next available technology that was available, which was called Dartfish. I'm sure many of you are familiar with Dartfish. It's used a lot in sports, especially for coaching and things like that. I was using Dartfish to quantify human movement. So I created a strategy, created a method by which we measured that. We would score it based off of that measurement. And after training, again, a lot of different therapists, over 200 therapists in this method, what I found is that it still was not objective enough. There was still too much subjectivity to it. because again, I'm making an eyeball call off of a 2D video. The other thing I found is that there's a lot of things that can affect the way that something looks or presents itself in a 2D video. For example, if I've got my camera slightly off to the right, it's going to look like you have a dynamic valgus when in fact you don't. So we tried to very much standardize, just like research, standardize the height of the camera, the pitch of the camera distance from the subject, all of that. And we still found that there was still too much subjectivity into it. So the next thing that we did is we went to Microsoft. I actually left the PT realm for about 3 years and worked with Microsoft on the Kinect camera. And what we tried to do there is we tried to program the Kinect camera to quantify these movements that we were looking at. I always felt that if I could do this in a markerless type of scenario, I could implement this in mass physicals in a much easier, much more efficient way. So we started doing that. Unfortunately, what we found is that the Kinect camera is not very accurate. It's got about a 25% error rate. So, you know, I say that because you need to be aware of that, because there are a lot of technologies out there that do use a foundation of the Kinect camera. And at the time that I was doing that, Microsoft actually put out a white paper acknowledging that error rate because of the way that that technology works. And I won't spend a lot of time going into the way that that technology works, but it becomes extremely inaccurate due to a lot of different factors like lighting in the room, like speed of movement, etc. So what we found is the error rate was just way too much for me. So we went back to the drawing board, came across a company that had developed an IMU, inertial measurement unit, and partnered with them to develop, at that time was called the ViMove AMI. When we launched that in 2017, from 2017 till about 2022, we had over 450 systems across the US. This says 60,000 assessments. We've done 10 more thousand since then, since the launch of our new system, and it equated to over 90 million data points. We learned a lot of information from version number 1. This is what it looked like. These are the wearable sensors. They were capturing movement at 200 frames per second. They were communicating that to what is called an RFD, a radio frequency device, and that would communicate that to the computer. The program would interpret all that information and generate an automated report, which we would then, as clinicians, we would then review that with the athlete, but then we would also use that for return play decisions, and we would also use that for driving of our clinical decision-making process. So this is, again, the whole reason behind building the database the way that we did was we knew that if we could capture large mass data sets, that's going to teach us a ton about human movement. So just to give you an idea, on the first 60,000 that we collected for every single movement that we were doing, that we actually created the largest movement database in the world. What that also allowed us to do is we assessed, we captured, we recorded over 4.9 million reps of exercises, over 180,000 minutes of core testing, and over 90 million variables. So from that, we were able to start creating some normative values of where people should fall as far as how much speed of valgus, how much valgus should you have, how much should your pelvis move, all of those things. So we were able to start creating some of that normative value. Now, what I will tell you is since that time, we continue to learn. We continue to learn that what puts one athlete at risk versus another athlete is very different. There are other things that fit into that, like the sport you're playing, like your age, like your gender, like your position in that sport, the level of sport, Division I versus Division III. So there's a lot of different factors that fit into that, which we are now mining all of that out so that we can start to get some normative value by age, gender, sport, position, etc. So some of the biggest lessons that I've learned from our first launch of the system, number one, dynamic valgus speed matters. is we were the first ones to truly put out there in the research community that dynamic valgus speed is really important. We all know, we can all prove it right here. You could stand up right now, put your knee to 20 degrees of valgus, and it's not going to hurt you. But if you do that same thing and you did that at 450 degrees per second, you're probably going to tear something. So we know that speed has a factor to it because both power and torque have a component to it. Therefore, more power is created, more torque is created, the faster the movement occurs. That being said, dynamic valgus speed matters. Now we have some recorded numbers of what that should look like. The other thing that we know is that pelvic control matters, both how much your pelvis moves and the speed at which your pelvis moves. The other thing is that it's now starting to guide us on what links in the chain, how many links in the chain are actually breaking down, because as speed goes up, what you have is you have more links in the chain that are actually breaking down. Because if your core is controlling and your ankle is controlling, your speed should be lower. As ankle goes down, speed's going to go up. As your core goes down, then also speed goes up. So it also guides us on how many links in the chain are actually being affected. Power variance. So we are validating this in the lab right now, but one of the things that I will tell you that we're learning that we have not fully vetted yet, and I'm very transparent about that. But what I will tell you, and it makes a lot of sense. Number one is if your power drops, if you have a degradation of your power of X over time, that you're going to be at a greater risk. And what I mean by that is on rep 1, if your power only drops this much, you're at a much less risk than if you drop this much. So there is a power component. There's a way to measure power. We have the way to measure power now. We're validating it in lab. We have a way to measure power now that if your power variance drops or degrades by a certain amount, that's also going to put you at greater risk. And if that is asymmetrical on your right side versus your left side, that's also going to put you at greater risk. So those are things that we're vetting out right now that soon that we will be releasing versions where the technology will actually be able to measure that for us. Other things that we know is that there is a direct impact of kinesiophobia on movement. So one of the kinesiophobia measures that we measure is called the TSK11. That's a Tampa scale for kinesiophobia 11 form. If you want a copy of that form, simply email me. I'm happy to send you a copy of that. It should be used. Paterno showed, and I may have this in his slides. Paterno showed that if you score 19 or greater on that test, that you're 13 times more likely to suffer a re-injury. So there is a correlation to the movements that we measure and kinesiophobia, and I'll share a little bit more with that in a moment. And also, there is an impact of concussion on movement. We know that if you have a concussion, from research, we know that if you have a concussion, you're 3 times more likely to suffer a knee injury up to 3 years after a concussion. So my question always, when McPherson first published that, I was like, well, why is that? Why is there a correlation to knee injury risk and concussion? Now we know. We know that there is a larger magnitude of dynamic valgus. We know that there is a larger speed of dynamic valgus in those who have been concussed. And clinically, what does that do for us, right? So now instead of in addition to doing stuff for your neck, in addition to maybe doing some vestibular stuff, in addition to maybe doing some stuff with your eyes closed, now I'm adding single leg squats. Now I'm adding single leg hops. I'm adding those things that I know are going to work on control of that dynamic valgus. I'm going to add some more core control, things like that. I'm going to be adding that into your concussion protocol, because that is addressing those specific measures that we've seen that are directly correlated to concussion. So again, I talked about pelvic control. This was a really good study that was published here in 2022, last year, that showed that lack of pelvic control increases knee adduction moment especially in landing. So what ends up happening is that as you land, and especially because a lot of people, we call this a retrotrendelenburg position. So in this position, they're losing the control of their pelvis because most of the time, because they don't have that glute medius strength to be able to stabilize the pelvis when they land. So what ends up happening many a times is they will bend their center of mass over in this direction. Now, what happens a lot of times is that this knee will drive into a dynamic valgus. And then what ends up happening is that the force vector from your center of mass is now driving, even forcing it more into a dynamic valgus position. And I shared with you, part of, that knowledge has helped me as a practitioner, because one of the things that I do when I'm training with somebody is I know if I can move your center of mass, I'm going to take you down. Right. So I know that if I can load you over to one side, that's going to be much easier because you're unloading one side. All I got to do is pop an ankle or something like that. And then you're going to go down. So that being said, that force vector and the adduction moment that it creates is much greater than if that person had control of their pelvis. So this dynamic stability has been around for a while. So there's been studies that have been showing it for a while. 2019, this particular study was probably one of the first ones that I was like, finally, somebody else is onto this. And it looked at dynamic valgus, or I'm sorry, it looked at dynamic pelvic control, and especially in single limb. And what they found is that those who lack pelvic control were more likely to get concussed. And those who got concussed resulted in decreased pelvic control. So again, I think that that's not the only thing that happens after concussion. You lose this pelvic control, but you also start to see greater increases in dynamic valgus magnitude and speed. And maybe it's because the pelvis is moving so much and it's creating that adduction moment that we just talked about, where you're getting those greater forces at the knee, causing it to move at a greater magnitude and at a greater speed. So this was a particular study from 2022 looking at triple hop, which is a very common movement that we do for return to play. And this was used for return to play criteria. So return to sport criteria. In this particular study, the surgeon and the PT cleared the individual. They completed sport-specific tests. They had an LSI of 90%, of greater than 90% on the quad and the hop test. But when they went in and measured them in a biomechanics lab, there was less than 80% symmetry in biomechanics. So LSI was good on performance of the test, but biomechanics was not good. This is one reason that we came up with the concept of limb quality index. Limb quality index, what I'll share with you in a minute, is a measurement of those biomechanical risk factors in addition to your LSI. So when we look at someone for a return to sport decision, it is based off of LSI and LQI, which therefore addresses this major issue that we've seen with a lot of these tests that we look at. So again, this was another study from 2022 looking at single leg hop testing alone. And unfortunately, what it found was that there was a fair association with performance of single leg hop symmetry and an IKDC, a KOOS, and ability to return to sport. So think about that for a minute. When it says fair in research terms, that's not good. Okay, you want a strong or strong correlation to something to make clinical decisions based off of that. To have a fair association with an IKDC and ability to return to sport, that's not very good. So again, it just tells me we got to get better at doing what we're doing, and we got to have better measurements. But it really goes back to, Ren, I keep throwing this one out there. This is from 2018. It's starting to get a little dated, but this was really one of the first studies that really highlighted you can have symmetrically good and you can have symmetrically bad movement. Because what this study showed is that even though you have symmetry in your movement, may not mean that you have the biomechanical, or you're controlling the biomechanical risk factors that put you at risk for an ACL injury. And we all know that. That's that athlete that jumps down, both knees go in equally at the same magnitude, at the same speed, putting their limbs at risk, etc. So here's that study I was talking about with Paterno, looking at the TSK11. I want to go down to the bottom of this slide. 19 on the TSK11. You're 4 times more likely to self-report decrease in activity. You're 7 times more likely to have a decrease in LSI and HOP. You're 6 times more likely to have a quad deficit, and you're 13 times more likely to re-injure. All of that said, there's 2 ACL risk measures, or there's 2 psychological measures used with ACL reconstructions. One is ACL RSI, came from Ann Weber out of Melbourne, Australia. It's a great tool. It has been shown to measure psychological measures, but what it's not correlated to is movement, and what it's not correlated to is ability to return to sport and re-injury rates with return to sport. Therefore, I use the TSK11 because the TSK11 has been directly tied to both re-injury risk as well as your LSI, as well as movement. Now, I don't have those movement studies on here, but there are studies out there that show that if you perform poorly on the TSK11, you tend to unload your involved side. So as a clinician, that's why I use the TSK11 versus the ACL RSI. I think I'm going to get more clinically meaningful information that I can change today to start to influence that ability for that athlete to return to sport. So this comes from a paper that I published back in 2017, really just a systematic review of all the different papers looking at the risk factors. Number one, LSI alone is not enough to make decisions for return to play. You have to look at the quality of that motion. So it's not just the symmetry of the motion, but the quality of what that motion truly is. There are demographic factors and history factors that fit into that fit into risk, and that can include your concussion history, your ACL history. You need to look at some form of kinesiophobia. We use the TSK11. You have to look at core stability, bilateral squat. You have to look at dynamic valgus control, both magnitude and speed. You have to look at fatigue. And since I've written that paper, I'd also say that you have to look at pelvic control. You have to look at the ability to stabilize the pelvis in single limb activities, because that has a big risk factor to it as well. So we had our old version. We used that on a lot of different individuals, 450 facilities. In July of this year, we have now launched our new version, which I'll share with you in a moment. We went from 1,500 data points now to over 3,500. We released it in the US, Canada, UK, Australia, and Africa. And the goal is, again, to collect a lot of data on a lot of individuals. This time, we actually use smaller sensors. These are also operating at 200 frames per second. These are actually validated within 2% of a Vicon system. So you're essentially getting lab quality data. It takes about 15 minutes per assessment. It's important for me to have something that you could efficiently, reliably, and valid, use in mass physicals. And so people see, wow, you're sticking 4 sensors on somebody, you do this over 15 minutes. Trent, I got 110 football players. There's absolutely no way that I could implement this kind of a protocol into my mass physicals. Well, what if I told you in my job, we do this with first responders, and we don't do it with 100, and we don't do it with 400, and we don't do it with 600. We do it with over 2,000. So we actually take 2,000 firefighters through this assessment every single year, once a year. And what we do is we have it down to where we process about 100 firefighters per day every single time that we're testing. Now, we have 5 of us to do it. We can run through this super rapidly. We actually review the reports with them, and then we use all of that information to create exercise programming for them to help mitigate risk. So the goal for me was to be able to implement some technology like this in a very efficient and reliable manner, where you can actually capture baseline data for making programming decisions. So with this system, obviously we're capturing data from all over the world, which is feeding into one massive database, which again is going to do nothing but continue to drive our knowledge related to human movement and how we can impact that. So part of the second version, this is just a picture of it in operation during a squat, also what it looks like. Obviously, it's a much more enhanced. We actually have an increased efficiency of use of the system. The accuracy is increased. We actually get pelvic data. Right now, we get how much does your pelvis move. Again, we're validating in the lab. The speed component to that. Speed's always harder to capture. We're also validating in the lab the power output component, because we want to be able to provide you both as a clinician, as clinicians, athletic trainers, and physical therapists. We want to provide you a tool by which you can also communicate this to the strength coach to show what those measurements are and how that is affecting power output. Because one, we know now, we highly suspect we will know better once we're actually measuring it. We know now that degradation of power has a big impact on injury risk. So we want to be able to cross the threshold from the athletic training room into the strength and conditioning room and bring those folks on board as well, so that we're all looking at movement in the same way, communicating in the same way, with the end goal of mitigating risk for injury, at the same time improving power output in sports performance. So there's also levels to the new version. We have levels of the AMI. So what that allows you to do as a clinician is, if someone's progressing through their ACL rehab, you can actually do various portions of that. We've also integrated the TSK11 into it, as well as an ACL decel test. So for a return to sport, we actually have a 30-yard sprint that they perform, max acceleration, deceleration in 30 yards, where we're able to get biomechanical data from that. We also measure that LSI and LQI, and I'll talk about that in a minute. And we went from 3,500 data points to from 1,500 data points to over 3,500. So this is what the sensors look like when they're placed on the individual, one on each tibia, one on thoracic lumbar, and one on L5S1. This is the LSI versus LQI. Limb symmetry index is simply that comparison of your right side to your left side. And what we know is that you can be symmetrically good or symmetrically bad. So top picture there, bilateral jump squat. What we see is that the athlete's knees are going in towards midline. The LSI in that case is around 92%. That being said, I think we would all look at that and say, you know what, this athlete's still at risk for an injury. So that's where this LQI comes into place. And that's a comparison of the quality of the movement on the right side versus the left side, and having quality metrics by which the athlete should achieve in order to get green, yellow, or red. So this is what our report looks like. Again, LQI is based off of how much valgus you have, what is your speed of that dynamic valgus, what is the depth of your motion, and then also how much does your pelvic tilt. This is where we give the overall LQI number based off of all of this biomechanical information. And again, these are the metrics that they're going for. So up at the top of the report, it always shows in blue what our normative values are based off over 10,000 individuals. This is our LSI report. And again, what it allows you to do is, at a very quick glance, see where your symmetry is at, but it also allows you to really analyze this. Like, so this right here, they are 80% symmetrically good, because those are both in green, although there's some area of improvement that can be done here. This one shows that they're asymmetrical, right? So you have one side that is definitely different than the other side. And then this one shows that they're symmetrically bad. So there's obviously a lot of area. Both of these numbers are in red, shows us a lot of area of potential opportunity. Again, at a very quick glance. And the most important thing is that there's something that we can do with that information right away. So what I want to share with you really quickly is a quick case study using this. This is a 17-year-old male wrestler. He's also a Brazilian jiu-jitsu athlete. He had a previous history of 2 concussions, no orthopedic injuries. His current complaints when he's in the gym, he's got low back pain with squatting. He lacks speed and power with his shots when he goes in for single leg, double leg takedowns. And he's had some left knee pain when hopping around on one leg. So when he has an opponent that grabs his leg and he's hopping around on his left leg trying to prevent the takedown, he's been having some knee pain with that. So here's what his results look like. Number one is on his squat. Number one, he's bending forward too much. So he's getting too much lumbar flexion, and he's shifting his weight on the average of 11 degrees. So on the average, over 20 reps, he's averaging 11 degrees over towards his right side. That means you may have some reps that are like 2 or 3 degrees, and you may have some that are 30 degrees. So this is something that's super easy to correct. It's not super hard. A lot of times it just takes some visual feedback, usually done with video during squatting motions, and that can be simply corrected. We see it in his plank, that his plank, he was not able to maintain his plank position for a very long period of time. And then also in his side planks. His side planks, both he fell down in lateral side bending. He also had rotation both forward on both of those. So he rotated forward on both for greater than 8 degrees on both of those. Next thing we look at is his single leg squats. We compare his right side to his left side. Again, this is where your normative values should be. So you can see he was moving an average of 10.98. His max amount of valgus that he had was 26 degrees. His pelvis moved an average of 22 degrees. That's a lot of motion for the pelvis. And his max that's a wrong number. That shouldn't be 20.38. On his valgus speed, we see that his valgus speed right here was 36 degrees. It should be 20 degrees. And his max was 87 degrees. His depth was good. Same thing, we can do that same thing, that same comparison on this side. Then when we go to his single leg hops, what we get here, again, his average 10.74. When I look at 10.74 and it should be 9, I'm really not that concerned about it. What I typically do is if I see that it's a little bit over on the valgus, the first thing I do is I jump over to the speed and see what their average speed was. So his average speed is slightly, I would say a little bit more than slightly above what should be. But then I'm going to go to his max. His max was almost 20 degrees of dynamic valgus, and his max speed on the hop was 218 degrees per second. So that's a lot of speed difference between what it should be and what his max was. So the report will actually allow you to go through rep by rep. So you can actually see where he was falling apart and did the max amount of valgus occur with the max speed, because that's the deadly duo right there. Is when you're moving into 20 degrees of valgus at very high rates of speed, that's usually where those injuries occur. So I want you to look at this one here. So his max on this one was actually 24 degrees of dynamic valgus at 346 degrees per second. Now his average speed was up quite a bit, but this one is the one that's a little bit more alarming. And again, I would really look through that report to see, was it when he had his max valgus of 24 degrees, was that equal to that 346 degrees per second? This is something I'm going to definitely be addressing. The other thing is too, is his pelvis is moving a lot. His pelvis was moving an average of 20 degrees versus the 10 that it should. So he's having a really hard time controlling his pelvis. And if we go back to his planks, we can see why, right? Because the planks are intentionally done before all the single leg, because I want to tire out his core. I want to tire out his glute medius. And then I make him go do all of this glute medius stuff where his core's got to be super active. His glute medius has got to be super active. So if those are not active, if they're fatigued out, which he obviously fatigued out by his plank scores, this is why we see in these numbers so significant in the pelvis. So again, I think over time, what we're going to see is that now that we're measuring pelvic motion, we're going to start to see and tie to and see correlations to pelvic motion and injuries. I suspect that lack of pelvis motion, if you think about it, your pelvis is moving 20 degrees on the average. So that means that some of those reps were 20, 30 degrees, right? If you're moving an average of 20 degrees when you hop, just think about how much how much wear and tear that does on L5S1. Think about how much wear and tear that does on that SI joint. So for our athletes with SI joint dysfunction, maybe this motion of their pelvis could be an indicator. I don't know that yet. But again, those are some of the correlations that we need to start to look at now that we have this objective data for how someone's pelvis is moving. So the other thing that we do for return to play, this is what our ACL decel looks like. Typically, I will do about 6 reps of this for return to play. This is only done for 3 reps on this particular one. And what it does, it shows you your absolute LSI. So LSI, it's your absolute LSI, which is a combination of your ground reaction forces, what is called your IPA, your initial peak acceleration, so how you're controlling your foot coming into the ground, as well as your contact time. So one of the things that we've seen is, number one, your ground reaction forces should be fairly symmetrical within about 100 newtons. Your ground reaction forces should be symmetrical. If there is a difference of 1G, that is significant. So I've seen some that are way off by 2Gs. We've seen some of our, especially during the deceleration phase, where an athlete will unload their involved side. I especially see that with those athletes who've had a hamstring tear. And then they go into that deceleration. You can actually see it in the data where they're actually unloading that involved side. So again, it just gives us some clinical measure, objective measure for some of the things that we may see visually, but it actually quantifies it to a number, which is designed to be something that can be clinically actionable, something that you can do in the clinic today to make an improvement on that. So people ask me all the time, how much time should I give between my testing? Well, there's studies out there that show us that, you need to at least give 6 to 8 weeks in order to observe clinically meaningful improvement. Now, that said, what I see is that in the initial phases, people will progress pretty quick. And then as they get into, the more minute components of their movement, as we continue to make those correctives, that's where you're looking more at that 6 to 8 week mark. The other thing I'll say is, this is not a BFR course, but one of the things I will say is that the addition of BFR is absolutely immense, the impact that it has on frontal plane control. So let me go to that. And that's the key concepts of training. What are the things that I've learned from objectively measuring movement on thousands of people and then creating exercise programming based off that? Number one is an exercise principle that I call regression and progression. So keeping in mind that we are creating a motor plan in the primary motor cortex every single time that we do exercise. And we want them to access that software in the higher centers. We want them to access that plan that we have created. And so what ends up happening is, so many times I've seen videos of people doing this performance training or return to sport training or end of ACL rehab training. And I see them doing these hops and things like that, and their knees are going into that dynamic valgus. And what we've done is we've just created a motor plan that when that athlete is in that fatigue state, that's the motor plan they're going to recruit to. So what I always say is that we have to create better motor plans to help people progress. So don't be afraid to regress a progression. So if you've pressed someone up to a single leg squat with the opposite foot off the ground and they get 5 reps into that, controlling dynamic valgus, but on rep 6 they start losing it, go to a split squat and finish those reps out. You're still getting the training effect, but you're reinforcing the movement pattern that you want and not the one that you don't want. Next thing is rapid neuromuscular response. This is a concept that I pulled from Mickey Hughes and some of his work. He doesn't call it this. This is what I call it. And it really is the body's ability to rapidly respond for stability. So I do a lot of perturbation training. What I see is a lot of perturbation training gone wrong. What I want to do when I do my perturbations with somebody, I want to give them a quick jolt so that their system has to immediately respond for stability. What I'm looking to do is not break them and move them and have them move into that dynamic valgus or have them move into that motion. What I'm looking to do is give them enough perturbation that they have to rapidly respond. That's what we're looking for, is that rapid response for stability. And you can train that both with perturbation training as well as other types of training. Third one is that pelvic control drives balance and force distribution, both with the center of mass displacement. The force vector that is created with the center of mass displacement to the lower limb can greatly impact the knee forces. So having that good pelvic control can truly drive not only balance, but also how the knee loads those forces. So pelvic control is absolutely essential. Early implementation of BFR, I alluded to that. And what I've seen, and actually one of the studies that we have going on is early implementation of BFR and improvements in dynamic valgus and speed of dynamic valgus. And what I will tell you is the preliminary results are awesome. For those of you, most of you probably use BFR. It to me has been a game changer. I actually teach a certification course for PTs and athletic trainers in BFR. And what's one of the things that I always say is that in 25 years of clinical practice, has probably been the biggest game changer for me. It is legit. The fact of what it does from a motor unit recruitment, the growth hormone release, the IGF-1, the impact that that has. The other thing I will tell you that is often missed with BFR, it is really important to consider the nutritional aspects of BFR, because there is such a systemic effect with growth hormone and IGF-1 and the impact on pH with driving into a hypoxic state and driving muscle, working the muscle the way that it does, and the decrease in the pH and the impact that that pH level can have on protein synthesis is absolutely essential to push hydration as well as nutrition. We could talk for a whole nother hour just about that piece of it. I won't go into that, but if you ever want any more information on what my nutritional recommendations are when doing BFR, feel free to reach out. Early implementation of straight single limb training, absolutely essential, especially for both pelvic control as well as that dynamic valgus. There is a strong link of kinesiophobia to movement. Strong link to kinesiophobia in your quad deficit. There's a strong link to kinesiophobia in frontal plane control. And there's a strong link to kinesiophobia in the lateral shift. If you correct lateral shift, if you correct frontal plane control, if you use BFR, kinesiophobia will not be an issue. That's what we see. If you improve the movements, what we see is that kinesiophobia drastically reduces. And then obviously addressing the neuroplastic changes. There are neuroplastic changes that occur in the higher centers of the brain. Again, I could talk a whole nother lecture just on that, but there are neuroplastic changes that occur in the higher centers of the brain, and you have to do some type of visual motor learning to correct that. One such device is QuickBoard. It's one of the ones that we use. QuickBoard is a platform. It's got 5 circles on it. It's got 2 on the outside, 1 in the center. It's got an iPad in front of you. The iPad lights up with one of those circles, and what you're supposed to do without looking is actually touch that device or touch that circle. So the device will actually track your error rate. It will also track your speed at which you're able to do that. And what studies show is via functional MRI, you can actually see the changes in the higher centers of the brain with that type of training. Unfortunately, if you don't do that kind of training, that does not just come back. And that's part of the speculated reason some authors have gone to that might be causing some of this high re-injury rate, because we don't typically address that in the rehab process. So what's next for me? What's next for data? What's next for the EMI? That's really think big, like really big. Like I'm really trying to think like my goal is not to implement this in the US. I want to have a global impact on ACL injuries. And the first and foremost way that you do that is you do that through technology, and you do it through data. So we've launched the Andrews in the Hewitt study. That's going to be a huge stepping stone. We've got over 4,000 subjects that we're going to be looking at. It's going to be a long study. It's like 5 years, 65 sites across the US and Australia. Super excited about that one. He's been a big influence on his research has been a big influence on me. So that's super exciting. My goal is by 2028, we'll have data on over 1 million athletes across the world. And my goal is to complete a profile for an athlete. What should you look like for a 16-year-old female soccer player that's playing at this level? Like, what should your movements look like? What should your nutrition look like? What should your sleep cycles look like? We now are tracking all of those aspects. I'm tracking sleep cycles, I'm tracking nutrition, tracking heart rate through technology. And I want to be able to tie that both to movement as well as injury risk. So a lot of good stuff that'll be coming out of that. Just stay tuned. And then finally is our next version of the AMI. And I will say probably in the next 5 years, we will have a new version of this that will be self-directed, because where I see the biggest area of opportunity for, I work with police officers and firefighters across the U.S. It's been one of the most rewarding things working with true American heroes. And another application of that is our military personnel. Unfortunately, with the military, the data or the number of subjects is so great that it is prohibitive to using the technology as we have it today. They get 800 recruits a month. So you're literally having to process 800 people a month, and that is a ridiculous number. I thought 3,000 was bad. 800 a month is ridiculous. So what we want to do is move to a self-directed assessment where somebody can walk up to the iPad and hook the sensors on themselves, go through a series of movements, and then the system would kick out an exercise program for them. What that would do is that would actually allow us to scale that for military applications. And so I think there's a lot of opportunity there as well, both for sports, for fitness, as well as military applications. So again, if you want to, it's not a self-promotion. You don't make much on books, but if you want to do a deep dive into more of the science behind that, that's why I wrote this. I wrote this for PTs, athletic trainers, chiropractors, etc., to really just give a deep dive into movement, how we look at movement, what the specific movements mean, and more importantly, how you address that from a training and exercise perspective. So that's the conclusion of my presentation for today. I just want to say thank you. It's always an honor to speak to you guys. I got to do this presentation last year. To be able to do it again this year has been an honor. I hope that you walked away with something that you can apply tomorrow. I hope it was worth the time that was spent. If you have any questions, you can always follow me on Instagram. I'm very responsive through social media. Feel free to reach out to me. Happy to share any other information that I have, TSK11, any of the studies I mentioned, anything like that, happy to share it. So thanks everybody, and I hope you have a great rest of the conference. Thank you.